Hello, very good evening. I welcome all of you in this very important panel discussion in a very significant series which we are doing on infectious disease control. It is a knowledge exchange series on infectious disease control being supported by Mylan Pharmaceuticals Private Limited. And in this series, as we all know that currently COVID-19 pandemic has made us realize that yes, there is a great need of strengthen our public health ecosystem, especially in terms of infectious diseases, how to control them. And at the same time, when the country is facing COVID-19 pandemic, the country still is also fights with tuberculosis and hepatitis. So what can be done, how great solutions, great ideas, experts views and opinions and comments can come. That is our aim to do this knowledge exchange series, and we with some days of gap of some days, we keep on doing such discussion with the experts, decision makers, policy makers, and leaders from private sector, government sectors, to document their views and ideas so that it can help in improving the ecosystem infrastructure for infectious disease control in the country. And today we are so honored and we are glad to have eminent panelists to discuss on this important issue with us. And I introduce all of them once, and then we'll be going on with the discussion. I introduced Dr. Kamini Walia. She is senior scientist in Indian Council of Medical Research. Welcome, Dr. Kamini Walia, from ICMR. And I also introduce you here with a veteran and a very renowned expert here, Dr. Rajiv Kumar Jain, who is senior consultant for health in Indian Railways. Rajiv ji, आपका स्वागत है. I also welcome Dr. Sunil Kumar M, who is State Tuberculosis Officer in Government of Kerala. Dr. Sunil, welcome. I invite here Dr. Himani Yadav. I welcome her. She's the Deputy Director for Hospital Administration and IT in Directorate of Health Services, Government of Madhya Pradesh. Himani ji, आपका स्वागत है. And in the industry expert, we have a renowned industry leader, Mr. Naresh Hasija, who is Associate Vice President of Mylan Pharmaceuticals Private Limited. Naresh ji, आपका स्वागत है. Okay, so now as I introduced this eminent panel to all of you, the audience here, I now request for each of you to give your initial remarks, and I'll start with Dr. Kamini. I'll request you to please keep it for maximum 3 minutes so that we can have further more discussions, and we will also be seeing questions from audience here. So I'll request Dr. Kamini Walia to please put your initial remarks.
Good evening, everyone, and thank you for this opportunity to share some of the concerns that we from Indian Council of Medical Research have around the antimicrobial use in the COVID patients. Now, as most of you would know that, COVID patients usually present with the picture of viral pneumonia. It is very difficult to differentiate between the viral and bacterial pneumonia because the picture is somewhat similar. So that with diagnosis not being done for bacterial pneumonia, most of the patients are receiving antimicrobials. Now, bacterial and fungal infections have been very common complications in viral pneumonia, and this has been documented in many studies which have been published, although the exact burden is not known. But most of the patients, the Wuhan study especially mentioned that about 15% of patients also had secondary bacterial and fungal infections when they were admitted for COVID in the hospitals. Now, given this situation, most of the treatment which is happening is empirically. It is very difficult to collect blood culture or collect other samples for these patients. So that's why people normally avoid collecting these samples, and as a result, most of the treatment is empirically. there's also another challenge that antibiotics like azithromycin are being used indiscriminately. Now, azithromycin is one of the very good drugs which we use for many conditions. For example, there is one outbreak of typhoid last year in Pakistan, which was resistant to all the antibiotics except azithromycin, and that was a drug which was used to treat typhoid. In these patients is a cause of concern. It is not possible to avoid it completely, but it is definitely possible to rationalize some of the prescriptions that the way antibiotics are used. For example, by using the narrow spectrum antibiotic, by sending out cultures in time, and if we receive some report in the culture, we de-escalate use of from the broad spectrum to a narrow spectrum antibiotic. So these are some of the concerns that we have at ICMR, that we may see a ravaging impact of COVID-19 on the antimicrobial resistance, which is already a very important public health challenge, and we are already lagging behind in addressing that. Thank you.
Thank you, Dr. And you have raised really nice issues, important issues, and I will definitely come on that in later discussion. I would like to request Dr. Rajiv. Dr. Rajiv, you have worked for the railway ecosystem, especially the healthcare infrastructure in railways, very closely, and I'm listening to you from years on the healthcare in railways. I would like to give you your initial remarks and just throw some light on COVID-19 pandemic and railways, and infectious disease also overall. You're on mute, Dr. Rajiv.
Yeah.
Yeah.
Thank you, Mr. Karthik. I must acknowledge the wisdom of Milan as well as Elets to organize this knowledge series on infectious disease control, because I believe over the course of time, what had happened in the Indian landscape in general and healthcare landscape in particular, with the advent of non-communicable diseases, uh, communicable diseases, especially infectious diseases control, had been relegated to the background over a period of time. And that was reasonable also, that's valid also, and there was a reason that over a period of time, because of extensive use of sanitation and antibiotics, infectious disease in general had come down. But there was always a fear of emerging infections, and emerging infections, viral infections, definitely carry a risk. So, in this context, I would like to say that this pandemic underscores the importance of a syndemic rather than a pandemic of viral disease. Syndemic, I say, because there is a pandemic of non-communicable disease, hypertension, diabetes, uh, and of course cancer. And in addition, now we bought viral infections. And not alone, one should see this particular infection of COVID-19, one should see that in the context of influenza, as well as if you see dengue, chikungunya, a series of events where environment had affected mankind, and the imbalance between environment and human beings has uh, over a period of time has resulted in a shift from animal disease to human disease. Now, in the context of if you see the context of Indian Railways has a footprint all across the country, and it's essential for the economy to function if railways has to function. And it is, in as you know, it is the largest employer in the world. The workforce has to be kept working all the time, 24/7, 365 days of the year, which which is I think now this pandemic has shown that if you have your in-house healthcare system with definite welfare focus for the staff, you get the tangible benefit in terms of you're ensuring that your system do not suffer. You are able to operate in spite of a very huge load of pandemic, because Indian Railways continue to employ full-time medical officers, 2,500 paramedical personnel, 50,000, 125 hospital across the country, 585 health units in a single management system. Because of this, and in addition, 40% of the employees, about 14 lakh employees, are housed in-house. That is, they are within the railway premises. So this ecosystem ensured that during, I would say that during the last more than 7 months, the railways have continued to function. And because of that, economy has continued to deliver, like food trains, fuel. You can think of anything that needs to be transported to the rail infrastructure. In addition, if you had seen the migrants transported through rail network, and in addition, people who need to go from their home to their workplace and the place of their original residence, they were also facilitated. And we continue to run the railway stations as well as railway trains, freight trains, and passengers all across throughout this 9 months. So that, I think that ecosystem underscores the importance of public health and corporate management. So that will be
Right.
the opening remarks at the moment. We shall discuss further.
Thank you. Yes, Dr. Rajiv, definitely. We'll be moving on with the more points in further discussion. Before that, I'll request Mr. Naresh Hasija, who is from Mylan Pharmaceuticals, Associate Vice President. Mr. Hasija, in this context, how do you see the role of a pharma company? And as Mylan, what are you doing in this current scenario?
Thank you, Karthik. We treat ourselves the most essential commodity right now, and I think this we were strong believer as an organization because we are treated as a public health organization globally. Half of our business comes from public health, so we were really concerned when this pandemic started, and we prepared ourselves so well, and we thought, let us make sure three things. One, people who are already on the treatment, they should continue to get their treatments. Patients on chemotherapies, patients on chronic treatment, they should continue to get the treatment. For that, what we need to do, we did everything possible. And the second thing was, like, how do we make sure public health across the world does not get affected? Because most of the manufacturing is happening here in India. So I think all our supply chain, manufacturing, and I will say that distribution, whole system worked in tremendous efforts were put to really make sure this disruption does not happen. And the third most important thing was, what do we do for COVID? I think that innovation we wanted to bring, and fortunately we had good partnership with our partner, principal partner Gilead, and we could bring the treatment for COVID for moderate to severe cases, remdesivir in India. And I think I will say that pharma industry plays a major role, and maybe we will discuss the rest of things in detail. Thank you, Karthik.
Right. Thank you so much. After a perspective from center, then from a corporate, now we have two states joining us here today in this discussion. And I'll start with the down south in Kerala. We have the state tuberculosis officer joining us here, Dr. Sunil Kumar M from Government of Kerala. Sunil ji, can you hear? Yeah, Sunil ji, I will request you to kindly share your thoughts, please.
First of all, thank you for the organizers for inviting us for this wonderful presentation and group discussion on the infectious disease control. My discussion part will be confined to TB elimination activities already going on in the entire country, and special focus on the Kerala. Why Kerala is moving towards TB elimination? That is the first and foremost point. And Kerala, for a long time, in spite of high suspect examination, the screening for TB patients, our yield is only 1.5% positivity rate among the screened patients. And moreover, when we started screening the Schedule H1 surveillance study, what we observed that sales of the TB drugs in the private sector is coming down. And when we look into the pediatric TB case also coming down. So all these pinpointing towards that Kerala can go for TB elimination. In this context, we launched TB elimination activities, with mapping of the vulnerable population of the entire state and how to ASHA worker as well as the multi-purpose workers in the general health system was utilized to go door to door screening for the TB suspects and picking up the suspected vulnerable population and making the list available of vulnerable population in each panchayat. So each panchayat will have a vulnerability list. Based on this list, the suspects are screened periodically every quarter based on their symptomatic symptoms. And in spite of the COVID activities also, we were able to maintain a good achievements in the private sector. That is the most important thing. But the public sector, the cases came down because the screening was very low. Why this happened? Because outpatient attendance in the PSCs came down, and also the laboratory technicians were feared to do this sputum microscopy due to fear of getting infection. And so what we do, we had moved towards the molecular diagnostic facility. The CBNAT as well as TrueNAT was widely made available within their government resources to the designated microscopy center throughout the state. And so now we are picking up the cases. Earlier, we were backed by around 50-60% of the cases were not raised during the COVID time due to this year. Now we are in the position to pick up the case. But what is happening in the private sector, that is the most important. We established a steps and a system for TB elimination in private sector, so that each and every case is coming to the private sector is getting notified, as well as the STEP Center act as a nodal point between the public sector and private sector. Whatever things that are enjoyed by the public sector patients will be channelized to the through the STEP Center to the corporate hospital patients. That was one of the major achievements that we were able to maintain the notification in the private sector better than the public sector. And what about the other factors, determinants of the TB in Kerala? Most important determinants that we noticed is diabetic cases and contact cases, contact of the TB cases. It comes around 14%, and diabetics constitute about 17%. And these determinants that the migrant population coming from the North India, therefore job in Kerala, that is also another determinant that leads to the development of tuberculosis. And major factor that we observed is this non-communicable disease. And this non-communicable disease is contributing to the death of the TB patients in the state. Roughly around 4% death is happening due to TB in Kerala, in spite of our advanced public health system. Primary, secondary, and tertiary care service are so strong that the TB service is available throughout the state up to the sub-center level. That means the grassroots of the public health system. So there is no need, then there is no demarcation between public sector patient and private sector patient. And private sector patients enjoys all the benefit of public sector through the STEP centers. And another important landmark that paved the way for the TB elimination is annual ARTI study conducted by the National TB Institute around 10 years back, 2005-6 period, also show that Kerala is the state where TB elimination is possible, where the transmission rate is only 0.4. And taking all these into consideration, and also the treatment support system for the already registered TB patients, that is one of the major achievements that we can put in you. Because treatment support center is available to all the TB patients in the coming under lower economic strata. By the treatment support group will support the TB patient during the treatment through financial as well as social support. And this contributed to the better treatment outcome. Around 94% is our success rate in the Kerala state. And coming to the drug-resistant TB also, we are having the lowest number of drug-resistant TB in the entire country. And our treatment success among the MDR TB patients is also comes around 65%, top in the country. And this is the overall in nutshell what how our TB program is going on in our state of
Right.
Kerala.
Dr. Sunil, thank you so much. It's great to know that in spite of all the major resources are involved in COVID-19 pandemic, you are successfully taking care of the non-COVID infectious diseases like TB in Kerala. Thank you so much for sharing these thoughts. I will now move on to Dr. Himani Yadav. Dr. Himani Yadav, who is Deputy Director for Hospital Administration and IT in Directorate of Health Services in Madhya Pradesh state, government of Madhya Pradesh. Dr. Himani Yadav, I would like to ask you that how you are structuring this healthcare ecosystem in Madhya Pradesh in this COVID-19 pandemic. Dr. Himani, I think we lost the connection here. Can you hear?
There is certain kind of network disturbance here, so that is why I am kind of connecting and disconnecting again and again. Coming onto the platform, listening to the eminent people from across the country, from center, from corporate, from state authorities. As far as me being a state health officer and looking after basically the health administration and the hospital administration aspect behind the infectious diseases, the strategy which we adopted when we got a hint that COVID might strike even our state when it entered the country. So way back in February itself, we started with our strategies so that we could contain the disease and could limit the infection within the population, because we handle the whole population of the state as a whole. So the strategy that Madhya Pradesh developed began from understanding the disease, the epidemiology of the disease. Secondly, we had to manage the limited resources that we have. Thirdly, was to provide treatment of the people being affected by the disease, because majority of the patients that were initially reported were the ones who traveled in from international travel, who returned from international travel, or from the disease affected areas of the country. Fourth thing that we had to manage was the prevention of the disease amongst those who were not affected by the disease. And the fifth thing was to make infrastructural arrangements in our hospitals, because we were not ready any day for infections to happen in our state, as we did not face an epidemic since a large part of time. Apart from containing the disease and infectious disease epidemic, we had to ensure already endemic infectious diseases in our state, as well as Rajiv Kumar Jain sir rightly stated, that it is a syndemic where we are already having non-communicable diseases. We have maternal deaths to be taken care of, and also the newer disease that has emerged for us. So we worked on an evolutionary epidemiologic state, and henceforth, having my opening remarks right now, I would just adhere to these 6 steps that we as a state took together. We had a holistic approach towards the disease, where we collaborated with our Directorate Medical Education, where we involved medical colleges. And thirdly, we also took help from Ayush department in terms of human resources, and as far as IC was concerned. So when we talk about preventive strategies, we thoroughly worked on to prevention of the disease by generating awareness amongst the local people, amongst the population, in the local language, local dialect that they could understand. Secondly, I myself worked behind managing the resources, managing consumables, drugs, and equipment. Thirdly, I was one of the people who was involved where we had to also make infrastructural changes in our hospitals, because we weren't ever prepared for any kind of a disease which could face this kind of a scenario where it was so frequent for human to human transmission. And thirdly, we had to also work up on understanding the disease epidemiology. Every day the clinical part was changing, so managing the resources in terms of even clinical management was another challenge for us. So based on all these things, we could successfully, after 7 months of the epidemic, we could manage, and we could get a graph where there was a subsequent decrease in the case numbers. We have a fire we have better number where it comes to people who have recovered from the disease. We have faced mortality, but not to that extent. It was limited to the population, which could not economically affect our state. Thirdly, the number of new cases emerging is far less than what are recovering. So I believe Madhya Pradesh on one part, where during the lockdown we had the resource transfer, which was transport was highly hampered, where we were arranging resources from that stage to this stage, where we have now developed a new infrastructure, where we have strengthened our own public healthcare facilities. So, this were my opening remarks as far as this session is concerned.
Right, right. So, Dr. Himani, I will start with the supplementary questions from you only. I would like to
Sure.
ask you, definitely, Madhya Pradesh for, we congratulate Madhya Pradesh for this management in COVID-19 pandemic. But I
Yeah,
would
thank
also
you.
like to ask you that what about the non-COVID-19 infectious diseases? How did you manage
Sure.
them?
Okay. Although it was kind of a challenge, a huge challenge when it came to non-infectious COVID diseases, but we have already have a vertical approach to all the health issues in our state. So every state program officer at the same point of time was taking care of this thing, that we are not hampering any of our essential services as far as our outpatient department was concerned or our inpatient department was concerned. Thirdly, not only here we have communicable diseases which are infectious diseases, but we have vector borne diseases, and Madhya Pradesh is kind of endemic to our vector borne diseases as well. So we had our regular surveillance activities going on. Since we had to go for active surveillance for COVID, so we took the opportunity of our active surveillance activities to even do survey in the form of fever clinics. So all those diseases which are related to our fever as one of the symptoms, we used our network of Asha Karyakartas and our Anganwadis to list out the patient who was suffering from fever, mobilized these patients to our fever clinics, and got them tested at the moment for the kind of disease that they may be suffering from. Secondly, what we ensured was that our regular immunization activities were not hampered. They were to be going on, and using our rapid response teams and our medical mobile units, we tried to ensure that the delivery of immunization services was delivered to the person at the ground level to the most. So this is one strategy how we managed to even handle the non-COVID infectious diseases.
Okay, okay, Dr. Himani. So, after these two states, Hatiza ji, I would like to once again come to you on this. That we have seen that even during COVID-19 pandemic, the non-COVID infectious diseases are still the same, problems are the same, and the states are dealing with them also. Where do you see your role in states in terms of non-COVID infectious diseases control? You're on mute. Yeah.
Yes, Karthik. So basically, before COVID, I think we were known very well known in space of infectious disease. So you starting from HIV, I think every second pill in the world is made by Mylan, and we take this pride, and we really provide this access. While working with India, we do a lot of access program with HIV arena with NECO, and we are the largest supplier of HIV medicines to NECO. Coming to the second virulent disease in this space, like where we are very strong, is viral hepatitis. Whether it is viral hepatitis B, viral hepatitis C, you can see that we were the among the first company who brought treatment cost from $100,000 to $1,000 in India for viral hepatitis drugs. So we followed an access model with our innovator partner Gilead, and this cure rates were above 95% for viral hepatitis C. And we partnered with few states like Punjab was at the time, I will say that center of viral hepatitis C. There we partnered with them. We worked with them so closely. We did a lot of access programs. We went to route where we did whole kind of screening with them and connected all the screening to the treatment centers. And treatment centers at that time were very new, so we did a lot of capacity building. So I will say that whole patient journey for viral hepatitis was worked on in such a way in Punjab as well as in Haryana, which was the capital of viral hepatitis. And central government saw all this work happening across some of the states where load of viral hepatitis is very high. So central government came up with fantastic central scheme around viral hepatitis, and this scheme has been very active now all across the states in India. So after HIV, I will say that the most important and very prominent area for us is tuberculosis, because our Prime Minister has taken oath for elimination of tuberculosis from the country by 2025. So we are working very closely with Central TB Board. We are working closely with some of the state TB boards so that we can create a difference in that space. And not only we don't want to be only I will say medicine supplier. We want to be preferred partner. We would like to do a lot of access programs, and we really want to create a difference at the root while providing this access of medicines to the needy patients. So I believe, apart from COVID, we are very relevant in the space of infectious disease.
Right. I would like to thank you, Dr. Satija. I would like to ask Dr. Rajiv. Dr. Rajiv, how railways mechanism is like to have maximum of recovery of the people. Is there anything on tracking COVID-19 or screening? Is there any mechanism in Indian Railways regarding that?
Well, as you know, in India, health is a state subject, but pandemic being a disaster, the Ministry of Home Affairs, the Ministry of Health, in coordination with other ministries in Government of India, ensure that coordination happens and there is a continuous dialogue and exchange of ideas and exchange of facilities and optimum utilization of resources all across the country. So in that context, there was a need for coordination mechanism with the state governments, all the state governments, and all other ministries of Government of India. So in this context, Railways immediately started a 24/7 control room in the ministry itself, and with zonal railways also having 24/7 control room, and divisional control rooms also were having COVID controls, which normally is used for transport control. So during this time, the 69 divisions of Indian Railways, 17 zonal railways, and the ministry together were closely monitoring the COVID-19 situation. This was for two purposes. One was to prepare for the such capacity, to prepare for managing internal COVID patients. And also, second need was felt to help the central government, the other ministries, and the state government, where the need arises, for providing the healthcare facilities in an innovative fashion, and also ensuring that this is done in full coordination with the state governments. So, if in this context, I would like to highlight one fact. That also must be known to you, that the railway coaches were converted into COVID care centers Even in Delhi, we had around 800 coaches with 8,000 bed capacity located in 3-4 specified locations, where in coordination with government of NCT of Delhi, the facility was extended, and that facility was utilized in taking resources from Government of India, Ministry of Defense, and state government, that is Government of Delhi. And like till say about 2-3 days back, there was around 1,000 persons had availed this facility, and they have recovered. In addition to that, the railway hospital, 125 railway hospitals in the country, many have been declared as COVID facilities, COVID treatment hospitals, exclusive COVID, dedicated COVID hospitals by the state government, like in Mumbai, in Kolkata, in Delhi as well, and major cities are hospitals that were converted to COVID facility, which means during that time, the facility was being used for treatment of COVID patients, not only railways, but also civil patients as well, in a geographical location. Now we come to having manpower. The existing manpower was also supplemented by engaging additional manpower, and this all expenses were borne by the Ministry of Health. That is the, I think, major lesson through this pandemic, that a coordination mechanism effectively functions on the ground. Now,
Right.
additional requirement was to have the supply chain for drugs, vaccine, diagnostics. Many of the railway hospitals today have their own RT-PCR facility. Many of the railway hospitals are providing even plasma treatment under ICMR, and all this was under the standard treatment protocols specified by Department of Health Research ICMR and Ministry of Health and Family Welfare, and in full coordination with the respective state governments. So I think this is a model which will stand India in good state in the days to come and the years to come. We must strengthen our health infrastructure and also ensure that on the ground, coordination mechanism effectively happens. And last but not the least, the information management system. Every day, the management of information was being closely done, so that the best outcome for the patients from mild to moderate to severe is done. Even in asymptomatic cases, close monitoring was ensured. In addition, a communication channel for health awareness improvement was made, and also you must not forget, during all this time, normal facilities were also ensured. Normal healthcare facilities and normal transport facilities were also ensured during the entire 7 months that we have gone through this process.
Right, right. It's actually a humongous task being done by railways to deal with this pandemic. Do we have Dr. Kamini here? Dr. Kamini, your camera is off.
Yes, I'm there. Yeah.
Yes, I would like to request you to share your thoughts, Dr. Kamini.
Yeah, can you see me now?
Yes, yes. Yes.
So, as I mentioned previously in my comments, do you have any specific question for me, or you just want me to comment in line with what other speakers have said? Just
Yeah,
clarify.
that's what I would like to ask you. Yes, yes.
Okay, fine. So, all the previous speakers have alluded to, what actions they have taken regarding management of COVID patients in their state, and it indeed is a humongous task. Looking at the numbers that we have and the kind of, the healthcare systems, especially in the public sector and with private sector, not really coming forward as we would have expected initially. Now, of course, all the states have ramped up their facilities, and the management also is much better, which is being reflected in the low death rate. But again, once again, I would highlight the problem of antimicrobial resistance. Now, from the data that we are collecting from the tertiary care hospitals, which are part of ICMR antimicrobial resistance surveillance network, what we have seen is that the incidence of secondary bacterial and fungal infections in admitted patients is something like between 5% to 30%. So there is a 30% chance that a patient who is admitted to an ICU ward or a ICU or a ward of a tertiary care hospital will get a secondary bacterial or fungal infection. And most of the time these infections are polymicrobial. They are caused by bugs like Escherichia coli, Klebsiella pneumoniae, and Acinetobacter baumannii, and these gram-negative organisms, which have been conventionally known to cause hospital-acquired infections. Most of these infections are hospital-acquired. For example, in one of the hospitals, out of 300 patients, 42 patients got secondary bacterial infections, and out of 42 patients, almost 29 to 30 patients had got it in the hospital. The infection prevention control is something which ICMR has been trying to promote so that we reduce this burden of HAIs. This project has been going on for last 5 to 7 years. Unfortunately, at this point in time, the IPC is at all-time low. One of the hospitals reported that the hand hygiene is as low as 50% of the times, that a doctor is washing hands or sanitizing. I mean, we can't blame the healthcare workers. They are wearing a PPE suit. There are the double layer of gloves. Yet, this is something that we cannot get complacent about, because a patient can improve, from COVID. But if he gets a secondary bacterial infection, and looking at the way we are using antibiotics, we might lose more patients to secondary bacterial and fungal infections rather than COVID. Another observation that we have is that most of the patients are getting more than 3 antibiotics. Everything is being used, right from carbapenems to tigecycline to fluoroquinolones. Of course, I mentioned azithromycin, doxycycline. So with all these, so much antibiotic use, there is no thought that, what are we going to leave future use? And because the diagnosis is not happening in most of the patients, the antibiotic use just continues indiscriminate and rampant. So with this kind of antibiotic use and this kind of an antibiotic resistance developing, I see very less hope for effective antimicrobials once the COVID is gone. So once again, all the states should refer to the basic principles of antibiotic prescription. There is an ICMR treatment guideline which gives guidance on how antimicrobials should be used. For example, for a community-acquired pneumonia or a hospital-acquired pneumonia or a ventilator-acquired pneumonia. So those principles of antibiotic prescription, which should also be based on the right diagnosis, should not be really forgotten. And this is the time to adhere to them now that we are using so much antimicrobials in the COVID-19 patients. Thank you.
That's very important and very valid point. Even WHO listed this AMR to be one of the 10 top threats. So here I would like to ask you, Mr. Hasija, that here when we come to know that there is a misuse and overuse of antibiotics in the community and all that, do you think there is a need of a proper training to the healthcare workers, the gap to be fulfilled here?
I think, as Dr. Kamini rightly said, I think guidelines are the most important thing. Yes. Apart from that, if you see healthcare worker, not only healthcare workers, it's general public also, where like awareness about misuse of antibiotics, people are popping antibiotics during this time by self-medication. I think the bad impact of self-medication is very, very important to be highlighted in these kind of situations. Apart from that, the antibiotic guidelines, which are coming up very, very strong in our country now, slowly, I think that will be very, very helpful to really help us to save from antimicrobial resistance.
Right, Mr. Hasija. I will move to Kerala now. Dr. Sunil Kumar, I would like to ask you, you very beautifully explained how Kerala is dealing with TB in the times of COVID-19 pandemic. I would like to ask you, what have been the challenges in front of you to deal with TB when the world is dealing with COVID-19?
Yes, sir. Thank you, sir. Actually, TB elimination activities we were started around 2018. 2018 itself, we started talking about airborne infection control in hospital. Risk assessment in major hospitals were done under the joint leadership of HIV, Kerala State Risk Control Organization, as well as TB program staff. We have, and based on the risk assessment, we started advising the local self-government to renovate their hospital as per the airborne infection control measures. And moreover, the younger generation students were informed about handkerchief revolution. And the handkerchief was distributed throughout the school for all the students, and it conveyed them about the importance of cough hygienic and cough etiquette that has to be practiced. Moreover, all the TB patient diagnosed were provided with the AIC kit with the spittoon and this washable mask, as well as feeling for to disinfect the sputum that is spitted by the TB patient. And when the TB management during COVID period, was the most important thing was we started bidirectional screening. The COVID patients who are symptomatic for TB will be screened for TB, as well as the TB patient with found to be negative and is suffering from COVID, they are sent for COVID testing. This bidirectional screening we started from the beginning itself. That means around August itself. And Kerala started reporting the TB case in January itself. January last week we had the first case. But this bidirectional screening and all these activities started only by August. And regarding the TB management during COVID period, we ensure the availability of the drugs at a grassroots subcenter level, and TB patients were given 1 month stock at their home, delivered by the TB control program staff. This helped us in a big way in treatment adherence. And this bidirectional screening, as well as we arrange the sputum pickup transportation at grassroots level to the major centers. So TUNAT or CGNAT, and the hub and spoke model was practiced throughout the state for sputum microscopy. This helped us in big way in diagnosing the TB cases. And moreover, the linkage with the other non-communicable NCD program, as well as RPC program, helped us in strengthening the non-communicable disease control program activities.
That's right. Thank you, Dr. Sunil. Hastija ji, I would like to ask you again once here that as an industry expert or an industry leader or a solution provider, how difficult it is for you, like, in this COVID-19 pandemic to deal with all these things separately, or with all the different sort of infectious diseases, maybe COVID-19 or hepatitis or TB. What has been your experience?
So I will say that for us, I think staying at ground is very, very important, and providing the access of treatment is our crucial task. So I will give you an example here right now for COVID. I think we talked about viral hepatitis, we talked about HIV. In COVID, the essence was speed. I think as all of you spoke about, Dr. Himani gave a very good example of how Madhya Pradesh started planning in the month of February. So I will say that speed was the essence for us also. We thought let us bring treatment as early as possible, and in companies like ours, large companies, whole system came together and we made entry very, very fast. Right now, to give you feedback, we have partnered with more than 26 states in India. We are their robust partner, preferred partner for supplying remdesivir to most all these states, what I just said. And we have a highly, I will say that in this time when people were not able to move, we had digital supply chain. We used best services of the country, and we made sure people in small town also, if they want access to remdesivir, they get it. We developed a digital web link. I'll just tell you. And this digital web link, our intent is to make sure, see, in tier 2 and tier 3 cities, after ICMR guidelines, doctors are using in moderate to severe cases remdesivir. So we wanted to provide direct access of this medicine to all those small hospitals which wanted to really use it, but they are all COVID hospitals. Under all the guidance, we created this web link, and now treatment access will be available to tier 2 and tier 3 cities also, which was right now majorly available to all the large cities as well as the whole public health system of India. So I think I will say that hospital administrations as well as governments are really liking our way of getting into the route, and we are working very differently in this space so that access is not denied to anybody who needs it.
That's right, Mr. Astija. Dr. Himani, I would like to ask you that uh, what have been the major challenges in this COVID-19 pandemic duration to deal with these infectious disease control?
Um, as far as the infectious disease control was concerned, the first thing that was the major challenge was transportation of the consumables, drugs, and equipment. So it was a biggest challenge that we could face. Secondly, the procurement was also another challenge because due to the hampered transportation across the country, Mr. Hasija would agree to it. There was also issues with delivering of raw material to the vendors and the suppliers, and henceforth it was a challenge on their part to deliver the goods to us. So this was a major challenge that we have faced. Second major challenge was containment of the disease. Uh, Firstly, when the lockdown was there, due to the legislative and administrative hold, the disease was contained to some extent. But subsequently, as the unlock phases were getting opened, there was transmission which was difficult to be controlled. So the second challenge was where we faced that there was an increase in number of the patients for whom we have to arrange the testing capacity, not only for COVID, but for the other infectious diseases as well, because as the communication and the unlock phases were subsequently opening,
Dr. Himani? Okay, it seems that we have lost the connection here with Dr. Himani. She was actually sharing really good insights. Okay, so yeah, we are in the final stage of this discussion. So, if we get
I'm sorry,
yes, yes,
I lost
yes,
my
please.
connection due to some issues.
Yeah, continue,
Uh,
continue.
so, so we did increase our testing capacity in a way where we took the fever clinics as an opportunity. So, these two were the main challenges that we faced during the whole phase of. Still, we are facing the same things, but we're trying to compensate and we are strengthening our system. And third thing that we got an opportunity was from the private sector. Immediately, the private sector in our state readily were happy to provide us with their infrastructure and their HR.
Okay, okay, great. It was. I will now request for a closing remarks from all of you to the last stage of this discussion. I'll request Dr. Rajiv Kumar Jain for the closing remarks for this session, please.
First of all, I must say that this pandemic has proven to be a big opportunity for strengthening our public healthcare infrastructure. That's number one. Everybody, irrespective of the speciality or his qualification or his background, is now immensely aware of what infectious diseases are all about. In that process, the importance of ecology, environment, human animal interaction has been quite definitely understood by most of the people in the country, whether it is journalists or non journalists. Second, our planning process will get strengthened in the years to come because now education and health, which were relegated to the background as a result of little investment in the last so many years, is getting due importance. Social development in in preference to heavy economic development is a leveler. Number three, the ecosystem for strengthening training and education in the field of public health and non-communicable disease control, and entire ecosystem of diagnostics, devices, and pharmaceutics getting strengthened. As Mr. Sija also has pointed out, this pandemic has shown how important it is to develop our own research ecosystem for diagnostics, vaccines, and also pharmaceuticals, including active pharmaceutical ingredient from India. As you know, in even today, we are not manufacturing majority of at API. We are importing APIs outside India. Number four, this also has given a huge uh, opportunity for people to understand, whether people in the public sector or the private sector, how much they are resilient. The capacity to be resilient was undiscovered earlier. If you had seen how people without resources have survived and are growing again, contributing to the best of their ability to the economic infrastructure in our country.
Right.
Last but not the least, the process of infectious disease again has given due importance to the issue of how infectious diseases are caused. If you look at the basic way that we prevent is by use of mask, social distancing, and personal hygiene, hand washing. These three important steps, though basic steps, seem very low cost, but they go a long way, not only in controlling disease like COVID-19, but also tuberculosis and a huge number of other respiratory diseases. And also, don't forget that this also prevents us from inhaling smoke, smog, and also particles which are PM 2.5 and PM 10 and PM 5, which is a major contributor to respiratory illnesses, including cancer. So this process, there is these 5 issues I feel through the discussions have underscored these big, I think, advantages of people keep on saying negatives about it, but there are a lot of positives as a result of this pandemic. Thank you.
Thank you, Dr. Rajiv. Dr. Sunil, quickly, if you just conclude your thoughts.
Most important thing, this is a high time to speak about airborne infection control measures to be adopted in all the, at least in hospitals. Social distancing, cough etiquette, cough hygienic practice, spitting in public places to be banned. And another area that is the HR, health sector HR is a major factor that is affecting the even COVID management program. That has to be taken into consideration. And moreover, the intersectoral coordination with the local health government, social security mission, and other related departments will help us in a big way in managing the COVID crisis.
Thank you so much. And quickly, Dr. Himani, your thoughts.
Actually, I would agree with Dr. Jain that it was one of the opportunities that we could take. This pandemic was actually an eye opener for us, because then we could realize that how weak our public health system actually was, and how weak the understanding of infectious diseases was amongst even the educated class. Basically, this episode has not only given us an opportunity to strengthen our digitalization of the health, because because during this period only we could get an opportunity how well we could digitalize our healthcare system and strengthen, so that we could easily manage all our resources. Secondly, have being from the state side, I would also comment that it gave us an opportunity to strengthen our public healthcare facilities. Thirdly, it was a very good example to understand how intersectorally we could coordinate and we could holistically move in controlling the diseases, which eventually I believe would be again followed in the future as well. So this will be how I would end my remarks.
Rightly said, Dr. Himani. We should, a society should never let a crisis go waste. That's right. Mr. Asija, I would request you to please conclude the session with your final remarks, please.
So first of all, I would like to thank eminent panelists. I think it's really accepting this invite and really enlightening us with the different perspectives. So in my remarks, I will just say that like everybody has talked about like how do we prevent from COVID. I will say that I saw a fantastic example as a person. Huge discipline has come in starting from our families and starting in society, where like my 10-year-old daughter never allows me to walk out even in my lobby without mask, so which was like not a normal time for all of us. Secondly, a good example of public private partnership which has established during this time is amazing, is really amazing. I remember we have worked with state, I will should managing directors of procurement corporations, director of health, director of medical education till midnight. So these people are working right now. Let me salute all of them. Till midnight, they are doing extensive planning for their state. And I think I will salute this PPP, which has just emerged, where public sector has played a key role. And with this, I'll just close and thank you, everybody.
Thank you, Asija ji. And before we close this session, there's a small 1-minute video I would like all of you to please watch. And after that, we close the session. Can my team please play the video?
Is good good enough? That's what we ask ourselves at Mylan. When we see dreams getting hindered by poor health, we feel good is not good enough. When possibilities can be accessed by just a few, good is not good enough. When health comes with a condition of affordability, we know good is not good enough. For more than half a century, we at Mylan have helped create better health around the world. We market more than 7,500 quality products that help people in more than 165 countries.
Because good health gets better only when it becomes more accessible to all. At Mylan, delivering better health for a better world isn't our job, it's our mission. Mylan, better health for a better world.
Thank you. So here we wrap up a wonderful discussion. Which was a part of knowledge exchange series on infectious disease control, supported by Mylan Pharmaceuticals Private Limited. Thank you, everybody. We will, and the audience will come up with some other experts and leaders in next knowledge exchange panel discussion on infectious disease control. So we sign off here. Thank you so much, Rajiv ji, Sunil ji, Naresh ji, and Himani ji. Thank you so much.